The last talk for Symposium 3 is by Dr. Bettina. She's a senior colleague and a friend of mine, and she's a senior consultant in the Division of Colorectal Surgery at National University Hospital. She's also an assistant professor at Yong Lin School of Medicine at National University of Singapore. She first graduated from Friedrich Schiller University in Germany, and then commenced and did her surgical training in the UK, where she did her last year of training there in the Department of Colorectal Surgery at Oxford University Hospital. She has a special interest in medical education and was awarded the Oxford Educational Fellowship, leading to a MA in clinical education. Besides that, she also spent some time in Basingstoke, UK, at the National Centre for Pseudomyxoma peritonei. She's currently doing most of the cytoreductive surgeries and PIPACs in our hospital. And she's also one of the pioneers in Asia doing PIPAC for colorectal cancer patients as well. And she's going to talk to us today on PIPAC for peritoneal carcinomatosis.
Thank you so much for the great introduction, and thank you for having me today. So I've been tasked for the last talk in this section about novel therapies for cancer, of which PIPAC is obviously one. It's a relative recent technique. And I think I suffer the fate of my previous speaker from yesterday, that I stand between everybody and lunch at this point. So I'll try and keep to time. So why is there a need to talk about peritoneal disease at all, which is obviously the main reason why we're talking about this to start with? Is peritoneal disease so different to any other disease? And the thing that makes peritoneal disease or peritoneal carcinomatosis quite special is that it is a rather heterogeneous group of either primary diseases that lead to peritoneal metastasis or primary diseases of the peritoneum or metastatic spread from other disease primaries. The most frequently we see in this regard are from ovarian cancers, gastric cancers, and colorectal cancers, and the commonest primary peritoneal disease is probably peritoneal mesothelioma. And all of these things are quite a basket of disease and diagnosis that is extremely difficult to treat, especially since a lot of us are trained in particular organ systems and not so much looking at this as an encompassing disease entity. So a common feature of peritoneal metastasis is that they are relatively difficult to treat and different to other metastases into the solid organs. And this is a landmark paper from Franco that was published in the Lancet Oncology in 2016, which shows very clearly that the disease response of other metastases into solid organs, such as the lung and the liver, have a much better response to systemic chemotherapy than the peritoneal disease, which actually falls off the curve at the bottom there, as you can see on this graphic. So that actually means that peritoneal carcinomatosis is something that merits special attention. And what we're discussing today is, I hope to show you what PIPAC actually is, why we look at PIPAC, how does it work, and what are the indications for this. So PIPAC is actually, or stands for pressurized intraperitoneal aerosolized chemotherapy. And it is not anything sort of special new surgical technique, anything that we do particularly. It is what we consider a novel drug delivery technique. So it has been conceived by a doctor and an engineer. And the entire technology that PIPAC is based on is in this little metal housing that you can see in the middle picture there, which is the essential for this procedure called the capnopen. So this contains a nebulizer, which is connected to a high-pressure injector machine, which we use conventionally in the radiotherapy department for the injection of contrast, or in the operating theater predominantly for vascular surgery when they're running their contrast injections. And then the other thing you will obviously need to treat the patient is the actual chemotherapy. How does it work? It takes advantage of the physical laws, so it converts the liquid chemotherapy into an aerosol, a gas, which is applied under hydrostatic pressure, and therefore has got some superior pharmacological properties in the term of that it gets distributed more homogeneously in the abdominal cavity on the peritoneal surfaces. And because it is applied with pressure, it has got some deeper tissue penetration that we see with other techniques which actually apply the chemotherapy into the abdominal cavity. So why are we looking at PIPAC? So PIPAC gets the chemotherapy where it needs to be, but also gets it better where it needs to be. It has got an improved distribution within the abdominal cavity. It enhances the tissue uptake. It therefore has got better tissue concentrations because the chemotherapy penetrates deeper in. Instead of giving the chemotherapy as a systemic agent via the veins, and then it needs to sort of get into the peritoneum as such. So if you give a chemotherapy systemically, only about 2% of the blood flow will get into the peritoneum. It is therefore better tolerated by patients, and because of the way that we deliver it, it can be repeated using minimally invasive access techniques. But it is a cytotoxic therapy and therefore, of course, needs to be handled with caution. The potential clinical benefits of PIPAC, it can be used as an adjunct or it can be used instead of systemic chemotherapy depending on the disease and the disease profile. So we're looking at extraperitoneal disease or not. It is a minimally invasive procedure, as I just mentioned. It can be repeated several times, and usually we do this at intervals of about 6 weeks to 3 months. Because we are doing this as part of a laparoscopic procedure, it does allow the repeat assessment of the therapy effect over time. And it leads to a more homogeneous distribution onto the exposed peritoneal surfaces and the deeper tissue penetration of the drug itself, as compared with other delivery systems into the abdominal cavity. So how does it work? I think some of you might be familiar with this slide, which has probably been shown in other meetings as well. But this is what it looks like as a schematic. So you can see the high pressure injector there, connected to the nebulizing pen, and the chemotherapy gets distributed into the abdominal cavity, which has been set up with a pneumoperitoneum there. So it is delivered as a standardized procedure. There is a standard technique to this. It follows a standardized safety protocol, and there will be some standardized treatment regimens, which I'm going to go into a minute. So generally speaking, we derive the abdominal access via a standard laparoscopic technique. We are introducing 2 different sized trocars. One is a 10-12 millimeter, which accommodates the nebulizing capnopen, and the other one is the 5 millimeter trocar for the optical port for the camera. We will then insufflate under CO2 under standardized pressure conditions, usually to about 12 or 13 millimeter Hg. The first part of the procedure is to evacuate and quantify all of the ascites, which can also be sent for cytology. We will then proceed to document the peritoneal carcinomatosis index, the PCI score, after which we will take 3 representative biopsies from different quadrants of the abdomen. Following which the setup is such as I showed you in the schematic before. So the aerosolized chemotherapy will be applied via the capnopen, and then this is connected to the pressure injector with a recommended PSI pressure and a certain flow rate. This therapeutic capnoperitoneum sits there for 30 minutes. After that, the aerosol is evacuated, and this is quite important. This is all on a closed circuit. So the aerosol goes into the closed waste system, which is usually the anesthetic scavenger, into the wall suction. And before it gets there, it gets filtered through a microparticle filter. And the whole protocol has been evaluated via 2 different safety protocols in different settings and validated. And the things that lead towards occupational safety in this particular aspect, because we are obviously instilling chemotherapy under high pressure into the patient. There is the tight abdomen, which we need to ensure before we actually start the procedure. The procedure gets done in an operating theater with a laminar flow, so the air turnover is quite high. And then when the PIPAC gets administered, there's actually nobody in the operating room. Before we start the procedure, we have got a standardized checklist which gets ticked off to make sure that everything is in place and everybody is aware. So PIPAC is probably the only surgical procedure where there's nobody in the operating theater apart from the patient, of course. So this is what it actually looks like. The theater is completely empty. The patient is hooked up to the anesthetic machine. The anesthetists are doing remote monitoring on this. And the surgical team has also left the operating theater monitoring via the television screen. The PIPAC is then delivered via remote access control, and then for 30 minutes everything is monitored from the outside before we then let the gas exsufflate. So I referred to the standardized treatment regimen. There's currently 2 of those. One is based on cisplatin and doxorubicin. The other one is oxaliplatin. There is, at this point in time, no other chemotherapy that is delivered via this PIPAC procedure. This can be combined with systemic therapy or can be a standalone. And this shows a standardized treatment algorithm where the intercalated PIPAC alternates with systemic chemotherapy. Depending on the cycle that is discussed with the medical oncology team, we can either have 1 cycle of chemotherapy followed by PIPAC, or if there's 2 cycles in between, the treatment interval can be pushed by a further 2 weeks. But the standard is usually for the PIPAC to deliver it every 6 weeks. The cisplatin and doxorubicin dose has been evaluated in treatment regimen with single dose applications in patients with ovarian cancers. And there is currently a trial ongoing for the combined regimen of cisplatin and doxorubicin for the 10.5 milligram and the 1 milligram dose for the doxorubicin. For the oxaliplatin dose, initially we used a rather arbitrary empirical dose of 20% of the Elias regimen, which is usually used for HIPAC procedures of 92 milligrams per square meter. But I'm pleased to say that this is actually a phase 1 study that we did here in-house, which was a dose escalation study, and the recommended phase 2 dose after we dose escalated in our trial is now 120 milligrams, so slightly higher, where the tolerable profile was good for the patients, and we therefore made the recommendation that future trials should explore on this particular dose. Lastly, what are the indications for PIPAC at this point? So there is not a lot of evidence available. There is some. So this is actually a slide which I borrowed from the International Society of Diseases for the Pleura and Peritoneum, of which I will talk a bit more in a while. You can see that there's a lot of registry data available. There is a number of phase 1 studies. As we look towards the phase 2 and phase 3 studies, the evidence becomes lesser. So there is clearly room for more trial in this avenue. Oncological efficacy. So if we're looking at the clinical responses, so this is for ovarian cancer, it's quite heterogeneously reported, but there is clinical evidence which is a histological response on the biopsies between 60 and almost 90%. And a survival benefit of 11 to 14 months median. For gastric cancers, again, there is a response which ranges between 50 and 90%, depending on which studies you're looking at, with a median survival of 8 to 15 months. Colorectal, again, also ranges a clinical response-wise between the 70 and the 80%, on the median survival of 15 months. And lastly, for pancreas and biliary tract, which is quite a heterogeneous field, with response rates reported as 70 to 80%. However, that does not seem to translate into a superior median survival benefit, as you can see, particularly for the biliary tract. Mesothelioma is interesting because this is obviously quite a devastating disease where treatment is not particularly curative for any patient at this point in time. So the clinical responses for PIPAC in this setting were between 67 and 75% in patients with a survival benefit of 27 months, which is relatively good. There are a few contraindications for this technique. So it's absolute contraindications is patients with very short life expectancy where doing an invasive procedure will not actually enhance their quality of life. Contraindication is bowel obstruction, as well as patients who are on total parenteral nutrition or patients requiring gastric drainage via PEG tubes and NG tubes. Patients with decompensated ascites, as well as the situation where there would be a simultaneous intestinal anastomosis or a repair of the bowel required, in which setting the PIPAC is not recommended. There are a few relative contraindications, which is the setting of having extraperitoneal metastasis, where the PIPAC is obviously not going to be of benefit to those extraperitoneal disease. A patient with the ECOG status greater than 2, patients with portal vein thrombosis, patients who have previously had cytoreductive surgery and HIPAC, and this is predominantly considered to be an access problem, because in order to get the PIPAC delivered, we need laparoscopic access, and patients with cytoreductive surgery and HIPAC have a potential difficulty to gain safe entry into the abdominal cavity. However, if this can be achieved, then PIPAC is something that can be considered in those patients as well. And then there is those patients who have had a previous anaphylactic reaction to systemic chemotherapy, in which case either the patient needs to be monitored very carefully, ideally the substance needs to be changed for the PIPAC delivery. So after hearing all of this, where do we go from here, and how does PIPAC now fit into our current cancer treatment? The International Society for the Study of Pleura and Peritoneum was basically formed to evaluate all the evidence and to enhance the peritoneal and pleural diseases as a disease entity that merits further studies. ISOSPP is also the entity that conducts all of the standardized training and the workshops for any surgeon wishing to be certified for PIPAC. And it is conducting a lot of studies and collaborations with people who are interested in peritoneal disease all over the world. So the following slides are actually lifted off the PIPAC training workshop manual, and when I gave them off, it actually had the little ISOSPP logo on there to say that I've borrowed it from there. The source is sort of left, so I am very grateful to be able to use those slides to share them with you. So the place for PIPAC use is actually relatively difficult to define if we do not have any comparative studies, and we do have none at this point in time. PIPAC has not actually been tested as a randomized controlled trial against any other procedure, such as PIPAC versus cytoreductive and HIPAC or anything in that realm. Therefore, the current recommendation is for PIPAC to be performed within the framework of clinical studies when it is competing with an evidence-based therapy. However, in patients with peritoneal disease, there are many situations where there is no evidence-based therapy available anymore. And in these situations, one can consider the off-label PIPAC therapy because the disease is life-threatening if it progresses, and PIPAC can potentially induce a regression of the peritoneal disease in the salvage situation. So ISOSPP has come up with a working draft for multiple peritoneal disease entities of certain organ origins. So this one is for ovarian cancer. And there is a lot of evidence available. So the high-level evidence is the boxes that you can see here in green, and this obviously pertains to systemic chemotherapy. So through the slides, you will see that there is always the green box around the systemic chemotherapy as the first-line treatment. You can also see that there is reasonable evidence, high-level evidence for the cytoreductive surgery, where the PIPAC, however, is currently still under debate. And there is a number of trials either ongoing or planned in the realm of PIPAC, which you can see there. So this is the PIPAC, cisplatin, and doxorubicin. Similar situation for peritoneal disease of gastric origin. Again, high-level evidence for any form of systemic chemotherapy, regardless of the setting, and a lot of ongoing or planned trials in the PIPAC domain, as you can see here. And again, the PIPAC use in this setting is currently also recommended on cisplatin and doxorubicin. Colorectal origin, again, a lot of evidence for the systemic chemotherapy as well as cytoreductive surgery. So those of you who are interested in peritoneal disease will have probably noticed the debate that had been generated by the report of the Prodigy trial a couple of years back now, and the changes in the views of whether cytoreductive surgery plus minus HIPAC should be considered. There have been some changes in the practice following that randomized controlled trial. Then hepatobiliary and pancreatic origin. Again, the only high-level evidence we have here is again for systemic disease. Everything else is considered off-label at present, and there is no particular studies going on at this point in time. Mesothelioma, and I'm just going in the interest of time to allow us a bit of discussion a bit faster here. So this is the diseases of appendiceal origin. Appendix has not been mentioned before in any of the other slides, but it is quite an interesting entity, and we do distinguish between the mucinous neoplasms, high grade or low grade, which you can see on this slide here. There is no evidence of any level available, and this one is for the appendix cancers cancers of appendiceal origin. Interestingly, PIPAC in these situations are also cisplatin and doxorubicin based. So if we come to the summary of the current indications for PIPAC, it is considered a relatively promising but mostly regarded palliative therapy. It is not a curative therapy at this point in time. So it should be used in those patients where there is no evidence-based treatment available anymore. And the possible indications that we can foresee for PIPAC with cisplatin doxorubicin is the third-line treatment for ovarian cancers, second-line situation for gastric cancers, second-line for HPV cancers, in the recurrent situations of malignant peritoneal mesothelioma, in patients who have got intolerance or intolerable side effects of systemic chemotherapy, and in patients where ascites control in the platinum-resistant situation is a problem. The only current recommended indication for PIPAC oxaliplatin is a salvage situation in colorectal cancers, and there is obviously a lot of room for further studies in this realm. So the overall conclusion is that peritoneal disease is a common disease in our patients. It does behave quite differently from any other solid organ metastasis. The response has somewhat improved with the evolution of systemic chemotherapy, but not to the degree that we see in other solid organ metastasis. PIPAC should be considered as a novel treatment for peritoneal disease and can be introduced safely in clinical practice via a standardized protocol. It should be considered and tailored to individual patients as a local regional treatment strategy and can be used in addition to systemic therapy in those situations. However, everything should be discussed in a multidisciplinary team to achieve the best outcomes for our patients. And I'm pretty sure that there is a lot of research that we'll see in the coming years on this. Thank you very much.
Thank you, Dr. Bettina. The floor is now open for questions. Are there any questions from the floor?
Thank you very much, Bettina. That's really a great overview and experience sharing. What challenges do you see to yourself and to the greater community to practice PIPAC as a first-line intervention adjunct to systemic chemotherapy for early malignant diseases, whether they're gastric, colorectal? They're those patients of ours who have minimal disease, and instead of waiting for the metastasis to grow and then intervening with PIPAC, why can't, or can it be, or are there challenges to becoming a first-line therapy?
Thank you for the question, Asim. I think, so as I mentioned, so PIPAC is currently not considered a curative option. So we obviously need to distinguish between patients who have got curative options available. So if you're looking at settings where there is little peritoneal disease, you would probably more likely look at curative intentions. So I know that you're an upper GI surgeon, so for gastric cancers, PCI of less than 6, you would still go for cytoreductive and do a surgical procedure rather than giving the PIPAC. I think at this point in time, we shouldn't look at PIPAC as this is a technique that will supersede everything. I think it has got a place in the treatment strategy in conjunctions with other treatments. So we have got surgical treatments, we have got systemic chemotherapy treatments, we have got local regional treatment strategies, and PIPAC fits into one of those. The need for PIPAC or for any sort of treatments tailored to the peritoneum came about because systemic chemotherapy has not actually shown the benefits that we see in solid organ metastasis, and that is why people started thinking about alternative options to get the PIPAC into the area where it needs to be. So of course there's other options for getting intraperitoneal chemotherapy into the abdominal cavity, so cytoreductive surgery in conjunction with a heated intraperitoneal chemotherapy delivered at the time of operation, or intraperitoneal chemotherapy for gastric cancers and ovarian cancers, which is commonly practiced as well. So I don't think that PIPAC will replace all of those aspects, but it is certainly a procedure that has got a room to join different treatment strategies that we've already have available as an addition rather than trying to replace something. When should it be done? Ideally not as a last-ditch effort. So if there is a patient where there is an escape from systemic chemotherapy, where you see that there is a non-response or that the patient is actually progressing, those are the patients who should be referred early by the medical oncologists back to the surgical department. And in essence, this is an interesting surgery in the sense that there's very little surgery involved. So it is we are surgeons and we obviously operate and put the laparoscopy and have a look around and do assessments, but we don't actually perform any surgery at this surgery. It is a technical delivery of the chemotherapy into the abdominal cavity.
Bettina, perhaps one question from me. I think as you've mentioned, PIPAC is really used in the palliative setting for a lot of our patients. But I think one important aspect to consider in these palliative patients is perhaps their quality of life. So have there been any studies looking at quality of life in PIPAC or your own personal experience?
There is. I can't quote you the paper right now, but yes. So what is quite remarkable is that PIPAC has got a relative low risk profile. Particularly the PIPAC with the cisplatin and doxorubicin is quite tolerable by patients. So it is performed as a day surgery procedure. Patients don't even stay overnight. There is a big center in Aarhus which does the pancreas patients, and they have published their outcomes and quality of life data on this. They literally do this as patients come in, have it done, go home the same day. My own experience with the oxaliplatin, and I think my colleagues here in NUH can resonate with this, is that oxaliplatin leads to a possibly slightly more inflammatory response. The patients do get abdominal pain after the procedures, which we don't see with the cisplatinum doxorubicin.
Thank you.
Yep, speaking about surgery as well, with regards to adhesions, in your own personal experience, do you find that adhesions limit the access to the abdomen for PIPAC? And also does adhesions, or could adhesions actually affect the efficacy of PIPAC?
Yeah, this is an interesting question. So I think one of the major determinants of whether you can do the PIPAC procedure safely is whether you can get into the abdominal cavity. So particularly for those patients who've had previous cytoreductive surgery and HIPAC, this is always a bit of a problem, because if everything is stuck to the anterior abdominal wall, you run the risk of injuring the bowel as you get in. Adhesions themselves, if there's a few around, should not actually be to the detriment of the distribution of the PIPAC, because it's a gas. It will actually distribute itself through the abdominal cavity. But you must get in safely and must be able to create a pneumoperitoneum. If the adhesions are so dense that the patient doesn't actually inflate the abdominal cavity, can't create a pneumo, then again, PIPAC is not going to be working.
Are there any further questions online or from the floor? If not, we will call Symposium 3 to a close. Thank you, Dr. Bettina, for your time again.
Thank you.